This is a 68-year-old gentleman who presented with acute chest pain and dyspnea to our emergency room at the VA. He had recent admission to an outside hospital in the past 10 days for very similar symptoms. They didn't do a cath on him because he had severe contrast allergy in the 1980s, presumably with ionic contrast media at that point in time, but they had never really pushed that issue with him to get him recathed. His EF was 30% at the outside hospital. 6 months ago, he had a normal ejection fraction. He had elevated cardiac biomarkers. This is still the outside hospital admission, and dyspnea, and was diagnosed with pneumonia and was treated with levofloxacin and doxycycline. His past medical history is diabetes, hypertension, hyperlipidemia, PAD with a left fem-fem bypass, lap chole 20 years ago with unreducible umbilical hernia that's been there for the last 10 years. Why this is important will come up later. Infrarenal AAA, 3.2 centimeters. His blood pressure, when I saw him in the ER, was 90 on 60, heart rate was 88, respiratory rate was 20, cool extremities, elevated JVP up in his earlobes, soft S1, no murmurs, bilateral crackles, increased work of breathing. On BiPAP, he looks comfortable. Without the BiPAP, his SATs drop, and he doesn't look good. And the umbilical hernia is noted, which was not tender at that point. This is his ECG. And again, you can see this is a ischemic ECG with ST segment depressions laterally. All those are new. None of that is old. And maybe even a hint, small hint of ST elevation in AVR, if you would grant me that. This is his chest X-ray. As you can see, it's very consistent with bilateral pneumonia. Not. Yeah, I love that one. Beautiful curly B line here. Definitely not consistent with bilateral pneumonia. This is his troponin. His labs start coming back. Troponin of 11, which is again newly elevated. They trended his troponins down all the way to 0.08 at the outside hospital before they sent him home. His white count was elevated. It was elevated in the previous admission too. Again, that makes people think, oh, this is pneumonia. His lactate was 2.9. His BNP was 1600, and that's his ABG. So the working diagnosis that we had was, oh, maybe this is bilateral pneumonia again, or maybe this is pulmonary edema with cardiogenic shock, or is this something else? So my hypothesis was that this is a non-STEMI with cardiogenic shock, with elevated lactate. His blood pressure had actually been 70 millimeters mercury before they gave him some fluids and put him on a little bit of dopamine and acute pulmonary edema. I brought him up to the cath lab emergently. At that point, when I arrived, I said, let's just stop here, get consent for intubation, mechanical circulatory support, all of the above. So we did all of that in the cath lab. He had no family. And this is his angiogram. And everybody will look at the injections to the left and say, Dr. Kumar, that injection sucks. You're a very bad angiographer. These were all terribly damped. We weren't getting much better pictures. So, Shami, you want to take some discussion now, or you want me to just move on? Because we're running a little late.
Why don't we move on and then...
Perfect. So we had, there wasn't really a whole lot of time given this presentation to call the surgeon, so I called my chief of cardiology and another cardiologist who was there. Surgeons were not available at that point to actually come down and have a serious discussion. We decided to go ahead with mechanical circulatory support and complex PCI. This is the left main ostium. With the eagle eye IVUS catheter through it, there was hypotension. When we moved the catheter back, this was resolved. I think this was a point brought up on one of the earlier live cases. And the MLA there was 3.0, which is probably underestimated because we're probably missing the true ostium even in our measurement. This is his iliacs. We managed to get an impella through there and had a Judkins left 3.5 guide. So the first order of business here was we decided to go ahead, secure the circ. We stented the proximal circ with a 4.0 by 15 Zions. And if you take a picture, the mid circ didn't look that hot at that point, so I went ahead to go ahead and stent that with the 3.0 by 15 Zions there, and that took care of the circumflex, which then left us with the issue of the ostial left main and the LAD. It took a 1.75 millimeter burr, 155 RPM. We did 4 runs, and this was following atherectomy and pre-dilation. We then placed three stents there, 3.0, 3.5, and 4.0, and post-dilated all of these beautifully, did a pot, and did a nice final kissing balloon, and this was our final result. Beautiful result, MSA 16.6. I don't think anyone will fault this result here. So I was delighted, I'm very happy about everything and how things had gone. We transferred the patient to the ICU with the impeller in situ. He had some bleeding around the peel-away sheath, which required a couple of units of blood, and then that settled. His lactate normalized nicely. Over the next 30 hours, his blood pressure actually went up to 150 mercury. His urine output increased. We were able to wean off the impeller. His creatinine actually went down from 1.3 to 0.7. He was extubated the next day after passing spontaneous breathing trial. That's about 3 days post-procedure. After extubation, about 6 hours later, he says, oh, I'm having some stomach pain. It's not in the chest, it's in the stomach. We obtained a stat CT abdomen pelvis, and that is shown right here. This is the real image. I didn't just pull a textbook image. As you can see, the stranding of fat in that loop, which was concerning for a strangulated hernia. We referred him to to general surgery that recommended immediate laparotomy and cessation of DAPT and administration of platelets. A family discussion was had at that point. They and the patient all elected to withdraw care. He was discharged to the home hospice in 48 hours per his wishes. So what I came up with was, this was a difficult scenario with a complex patient with multi-system disease. The best of efforts can be stymied by an unexpected turn of events. And finally, I wanted to present this because this was my best case of the year, because it was a great moment in terms of humility. Thank you.
Well, it's a great case, and again, highlights sometimes you can get tremendous, what I would say is technical and clinical PCI success, and then you have something unexpected. And one of the issues with cases like this, of course, is it ends up being a PCI death, which is we won't have time to talk about it, but that's a separate topic that's very, very important, that somehow we need to sort out how to differentiate this PCI-related death from an elective PCI. But one question I did have, it's a technical question. I'm curious what Manish and everybody else on the panel would do. When I have ostial left main disease, sometimes I treat that first and then treat distally, contrary to what we generally like to treat distal and work towards more proximal disease. So here with the left dominant system, it can get very tricky. So sometimes I'll treat that ostium and then do the rest of the case. I'm just curious what others would do.
Yeah, so a good point. I think the key is, as you saw just with the IVUS, he had hypotension. And I think this is totally a just case. This is a shock case. So in New York, finally we have actually this, shock patients are not excluded for mortality hits. They're separated based on hemodynamics, which took a long time coming. But we do have that now. But yes, it is I would have probably done what you said, which is to put a nice stent in the left main and secured it. I think Gautam did that, basically pre-dilated and then secured just so that he could deep throat. So oftentimes you'll get a longitudinal compression of ostial left main stents when you're working, especially because he had to roto distally. And so unless you're going to use a guideliner and not have to keep traversing that left main. So if you dilate and can stabilize the patient, so be it, that's fine. Otherwise, you need to treat that up front. So
we had to rotor the ostium itself. The ostium itself was calcified. That's the problem.
Yeah.
Yeah.
If you rotor before, there was a risk that will occlude the circuit.
Again, the teaching for rotational atherectomy is that it doesn't, counterintuitive, but it doesn't increase your snow plowing or loss of side branches. It actually facilitates because of differential plaque modification. Here in this case, he treated the circ first, and that was fine, and it was a nice job doing that. I guess you prepped it and then stented it, and if it goes, it goes. But otherwise, you need to start with what you need to start with. You cannot do this case without mechanical support.
Absolutely. In
a left dominant system, I would have had at least everything ready.
I actually had a pacemaker on the table ready to go.
I think the point for everybody is routine pacemaker with atherectomy is associated with more bleeding when you're trying to get venous access. In these cases, I nowadays don't worry about getting femoral venous access. I get neck access to eliminate that risk.